The university is one of the seed beds of innovation. It always has been, but I think even more so today. And over the last 2 years, I've become involved with a collaborative research team of researchers from around the university interested in issues of health innovations in the global south. Basically, how do we create or how do we foster health innovations in the poorest of the poor regions of the world so that the hundreds of millions of people who live on less than $1 a day are able to lead and live humane lives. On the one hand, or at one level, we have the world's leading experts pushing the envelope, pushing the cutting edge of their specific discipline. And that ought to continue. That's where we discover new medicines. That's where we discover new compounds. That's where we discover new economic theories. When you bring multidisciplinary researchers together around a certain problem, they're creating a whole new cutting edge. It's not about pushing the cutting edge in a specific field. It's about creating a whole new cutting edge. A whole new cutting edge that can be pushed further, but one that's qualitatively different. One that I think is in many ways qualitatively innovative. It's not necessarily the most high-tech. It's not necessarily the razzle-dazzle that we see in science magazines, but rather it's about bringing together different scholarly points of view, different research agendas to create a whole new research agenda. And if you were to ask me, I think in many ways that's where the future of innovation lies. The reason why we brought together a multidisciplinary team is that we wanted to see these perennial world problems through different lenses. We wanted to see how an engineer understands these problems versus, say, how a medical scientist understands these problems versus, say, how a political economist might see these problems. And again, how we then can engage in a dialogue around a common concern and come up with potentially creative and innovative solutions. And one of the things that we wanted to look at was how rural health care was delivered, right? The sort of the most primary care of primary care levels of health care delivery. And we really grabbed onto what was a particularly intriguing problem, and that revolves around the issue of diagnostic testing. And diagnostic tests, of course, are a very small part of healthcare delivery and a very small part of resolving the problem of public health care in the global, or public health in the global south. But it's an important issue, and it's an important problem. So upon talking to physicians, upon talking to policymakers, village leaders, and villagers themselves, we began to get a sense of the decision-making process, by which very poor people in resource-constrained settings make healthcare decisions. And in many ways, it was in contradiction to, or it was contrary to what we would have expected. So in talking to villagers, they would explain to us, for instance, we live on less than $1 a day. For us to go and get a diagnostic test and then get follow-up tests would mean that we would have to miss 2 or 3 days worth of work. We would have to travel 3 or 4 miles, oftentimes on foot, to get this test. It makes no economic sense for us. And even if it did make economic sense for us, it would seem completely irrational to peasant villagers to get a test for which the best result was that there was nothing wrong with you. Right? Again, it made no sense. And in the worst case scenario, something was wrong with you, and then they were without the resources to do anything about it anyway. It's been very illuminating for us to actually be in the village, so that we're not simply trying to understand global problems from extant theories, but actually talking to people and asking certain questions that may reflect our own disciplinary biases, but taken together, excavate a completely new way of understanding these global problems. When we're in the field, the engineer is looking for technical solutions. The management scholar is looking for organizational innovations. The medical scientist can actually give us some sense as to what ought to be medical priorities. How do we tie symptoms to illnesses, to treatments, etc. And a political economist such as myself is interested then in the economics of this and the political context in which all of this is working. So whereas if we were to be in the field on our own, we would only have one take. We'd only see one reality. What this means then, or the implications of this research, is that basically what we've primarily been concerned with, those of us dealing with global health, is about the provision of health. It's about delivering health. It's about putting into place the infrastructure and systems that can bring health care to those in most need and those in resource-constrained settings. But what this research is showing us, at least the tip of the iceberg, is that there's a prior question that we have to begin to interrogate, and that is, how do people who are very poor make healthcare utilization decisions? It's meaningful to bring healthcare. It's meaningful to deliver it, but if it's not utilized, then those whose lives that are trying, those whose lives that we want to improve and themselves want to improve are not being improved. The bigger question that's going to come out of this that I anticipate is going to be the question of, well, what do we do with this knowledge? And I think that what we're going to be confronted with here in the World Health Organization and governments around the world as we are at the forefront of this global health research is, do we adapt health systems to local situations and local contexts, or do we engage in what economists call menu manipulation and change the incentives to try to alter the behavior of people living in these resource-constrained settings in the global south? I don't know what the answer to that question is right now, but I think it's important that the type of research that we're doing is forcing us to confront these very, very critical questions that are perennial, but I think in many ways have been put on the back burner for quite a while now. And hopefully, and I'm quite confident, will have an impact on policy and ultimately on what are frankly hundreds of millions of people living in conditions that we would consider here absolutely inhuman.